Welcome to This Week in Health IT Influence, where we discuss the influence of technology on health with people who are making it happen. My name is Bill Russell, recovering healthcare CIO and creator of This Week in Health IT, a set of podcasts and videos dedicated to developing the next generation of health IT leaders. This podcast is brought to you by Health Lyrics. Professional athletes hire coaches for every aspect of their life to ensure top performance. Healthcare technology is much more important, yet too many leaders choose to go it alone. Put me in your corner. Wow, that sounds hokey. I'll fix that later. Visit healthlyrics.com to schedule your free consultation. If you want to support the fastest growing podcast in the health IT space, here are 5 ways you can do it. Share it with a peer, share it on social media, follow our social accounts, LinkedIn, Twitter, and YouTube. Send me feedback. Love your feedback. It's very helpful. And subscribe to our newsletter. And then one last thing before we get to our guests, we have 2 new services I want to make you aware of. One is This Week Health Insights. We made the commitment about 18 months ago to invest in the careers of people in health IT, and a lot of health leaders have stepped up and been a part of that, and now we've packaged that up, packaged that wisdom up, so you can receive it in your inbox every Tuesday and Thursday. I take a short snippet from these interviews and answer the question of so what, try to make it pragmatic, something you can apply to your career. Today, you can visit thisweekhealth.com/insights. And then the last thing before I get to our phenomenal guest for today, This Week Health staff meeting is a result of a conversation I had with a couple of CIOs. And that launches in 2 weeks. And it's designed to expose your team to new thinking and get the conversation going. Essentially what that's going to be, again, is a short snippet from industry leader with 2 discussion questions. We're going to send out 1 of those per week, and you can share it with your staff, have the conversation, and get your staff meeting kicked off on the right foot. You can pre-register for that at thisweekhealth.com/staff meeting with no spaces. Okay, enough. Today I'm joined by 2 guests, 1 returning and 1 new guest to introduce to the community. Ann Weiler is the CEO of Wellpepper and a returning guest who brought along the CTO and co-founder of Wellpepper, Mike Van Snellenberger. Good morning, both of you. Welcome to the show. Ann, did I get your name right?
Got my name right, but there's no ER on Van Snellenberg.
Oh, gosh, I did.
It's all right. There are much worse ways to butcher my name. So
at some point, I'm going to have to get the names right before I have a show with you guys. Wellpepper's still the name of the show, correct?
The company, yes.
The company, of course, I messed that up too. This is what happens when I wear a tie. I get all flustered. It doesn't happen well. Wow. And this is the first of the shows that I'm doing with 2 guests. And as you guys know, this is sort of a balancing act. Not only because Ann is actually standing on a server to do the show, so the height disparity isn't too bad, but it's a balancing act to get both of your perspectives on a lot of different topics. So I'm looking forward to this. The topics we discussed ahead of time, we're going to talk about machine learning, data protection, data bias, big tech, privacy, a bunch of other stuff. And we're going to try to do all that in a half hour. Are you guys ready for this?
We are ready.
Yeah.
And with the slant of patient-generated data, because that's what we're all about here.
Absolutely. That would be great. So, Ann, let's start with a quick update on Wellpepper. What, if anything, has happened or changed since the last time we spoke, which was at HIMSS?
Well, I got over the flu. You remember I had the HIMSS flu. But yeah, lots of stuff. We announced a partnership with eVideon, who do inpatient systems, and that's as a result of customer demand. What we're seeing from customers is wanting to have a few integrated systems that really cross the whole patient experience. And you're seeing that in health systems hiring chief digital officers and really thinking about this end to end. We love the folks at eVideon. They've taken a very patient-centric approach, strong product architecture, and it was just a great fit to announce that partnership. So that's one of the things. We got the results. 2 of our studies have been published in peer-reviewed journals. So we had a study with Boston University, people with Parkinson's disease, and a study with Harvard for seniors who are at risk of adverse events. And so both of those have been published. Some of the great highlights I can share from those is the Harvard study. People had improved mobility by working with a remote care plan and a remote interaction and check-in. So they had improved mobility over the course of the year. but more importantly, they had reduced ED visits. So true cost savings that you can prove from these interventions. And then our friends at BU, we deployed and launched a new study with them. They've got a 5-year NIH grant for a broader Parkinson's study that includes a behavioral health component. So not just the medical and physical clinical intervention, but the behavioral health side of it as well. So very excited about those studies. It's very important to us to prove, independently prove that what we're doing works in empowering patients to follow their care plans. And then for our customers, we've deployed new scenarios in orthopedics, shoulder and ACL surgery, in neurology, new headache care plans, and we just deployed an Alzheimer's intervention. So again, proving that patients can and will self-manage if you give them the right tools, but also our platform approach, which was basically that a patient engagement experience needs to support all patients, whatever age they are, and all conditions.
Wow. So a ton has happened. Can you provide me those links? I'll include them with the podcast and the video, because that's really important research. That's essentially saying, hey, we have digital interventions that are producing results. That's essentially what those studies are showing us.
And we've taken the theory that patients can and will self-manage if you give them the right tools. The BU study, patients who came into it with a lower patient activation score, so that's basically they feel less confident about their ability to follow their care plan, they saw the greatest gains. So again, that goes back to sometimes when you talk to clinicians, they say it doesn't matter what I tell the patients, they won't do it. That's not true. It's about how you tell them, how you support them, and how you basically, provide them that link back to the care team if they need additional help.
Fantastic. Well, Mike, we're going to introduce you to the community here. You wrote a really cool article on self-driving healthcare, and the concept was around machine learning and data, and essentially how to help healthcare have its self-driving moment. Give us a little background on or premise of the article before we jump in.
Thanks, Bill. I'm happy to be here. Long-time listener, first-time caller, I guess. So yeah, the premise of the article is we're super excited about the opportunity for machine learning in healthcare. And one of the things that we discovered when we started looking at what the possibilities were is that a lot of the data that you have in healthcare is really still siloed in the EMR. And so you have a lot of billing data and diagnostic data. And that kind of data is good for some things for machine learning, but really doesn't enable healthcare to have really a robust, self-driving moment in the same way that machine learning is helping to propel the self-driving car and autonomous car vehicle industry. So if you think back 10 years ago in self-driving cars, there really was no such thing as a concept of a self-driving car, and it was really these large government studies that were millions of dollars to try and get a car to drive short distances. And really the presence of data was what catalyzed that movement in self-driving cars, where you could get a lot of data about the environment and about mapping. And the problem we have in healthcare is we just don't have that kind of data about patients when they're out on the street in a way. We have a lot of data about what happens inside the four walls of the hospital, but not a lot about what happens to patients when they're not in the hospital. So you can think about the difficulty of, let's say all you had was shop maintenance records of a car and fluid level measurements, and you tried to train a self-driving car off of that data. You can't do it. You need a lot more of a robust data set. And so that's really what we've been focused on, is helping to capture that data set of, how do patients interact with the health system when they're between visits, and using that data set to, in the future, be able to help augment and eventually maybe start automating care for patients.
So let's stay on cars for a second, just to get the context right. So machine learning is a subset of AI, but machine learning is the act of training the machine by example. So it learns by example. So I guess from your article, about 15 years ago, they had government maybe sponsored studies that you had universities out there with teams, and they were trying to get their cars to drive 10 miles, 50 miles, and those kind of things. And then the big breakthrough was Stanford, and they essentially taught their car to learn by example. Can you give us a little idea how that works? And then we're going to come back to healthcare, because that really brings up some of the biggest challenges of training machines with healthcare data.
Yeah. So the way that self-driving cars evolved really was, as you say, the big breakthrough was using example-driven data to train a machine. And that was a combination of sensor data and visual data captured from vehicles, and not training by algorithm. There were many companies that tried, or many, I guess, participants in the research that tried that approach, where you try to have a smart person sit in a room and say, well, if you see these conditions, then do this. And instead of doing that, they said, well, let's just collect a whole bunch of data. We'll label which things are the good things to do, the outcomes that we want, and then we'll let the machine learn about how to produce those outcomes. And so it's a great technique when you have kind of very large input spaces of variables and a set of things that you want to drive towards from that, which is actually a lot like healthcare. You have a whole bunch of data about people, whether it's their genomic information, their diagnostic information, their diet and exercise, activities of daily living. All of that data, if you were able to quantify it, is a fairly large data set. And so it'd be really hard for a person to decide, well, here's I'm going to weight this factor so much and weight this factor so much. But machines are really good at that. If you said, here's 1 million people, and we can observe from all of this data that we collect about these people, where we get good outcomes and poor outcomes, and which things might lead to diseases or not, then we can start to learn from that data and build predictive models for people's health. But you need to start.
Is it quantity of data or is it quality of data? I know the answer should be both, but which is more important?
Both. I mean, certainly machine learning works best with large quantities of data. It's notoriously data hungry to train most kinds of models. But paired up with that, you need to start with data that is of high quality. One of the problems we have with healthcare data is a lot of the data we get from EMRs is really been tweaked towards billing purposes. So, for example, we see a predominance of procedure codes that skew towards higher billing rates, even though that may not be a fair representation of the observed diagnostics and the observed procedures that are actually needed for patients. So there are some kind of data cleanliness issues that you need to overcome when working with some of the data sets that we have in healthcare today.
So if you look at what we're doing, we've got a contained experience. So we've got patients who we know what disease or condition they have based on the care plan that they've been assigned. And we've got the things that they've been assigned to do. So we know what they're supposed to be doing, and we know how they're doing against that care plan. So with a smaller data set, we can start to get insights from this patient-generated data, which is very different than saying, there's one approach that says get as much data as you can and try and find some sort of insight in it, which is great if you're, a large academic researcher, and you can keep doing regressions on that to start to find trends. We can start from a hypothesis. So for example, we've got somebody on a total joint replacement care plan after surgery. We can say, all right, we're going to look for factors that might predict readmissions. Well, we've already got a smaller surface area. We don't need quite as much data to be able to find those things that might indicate an adverse event. And so we've actually trained a machine learned message classifier on patient-generated messages for patients who are part of that sort of post-ambulatory surgery care plan, and been able to say, hey, this type of message seems like it might be a problem. And so you can do things if you know that, if the good data if the data is good in and you know what the data is for, you can start to find these insights a lot faster. And I think that's, some of the challenges today of machine learning are people are just trying to take these massive data sets from the EMR that weren't necessarily developed for those insights and trying to find those insights. Now, that's the job of like Google's doing that, Amazon's doing that, Microsoft's doing that. They have enough compute power, they have enough people and enough money, quite honestly, to do that. I think where where we're looking at it and where health systems should be looking at it is a little more contained. And I think you see that with health systems. They're looking at things like, how do we predict sepsis? So, what's this, rather than what's all the data, what's the insight, going back to the way we're looking at it, which is on this care plan, what's going to indicate someone's about to not be adherent? What's going to indicate that they might have an ED visit? All of those things.
Yeah, but here's the distinction I want you guys to sort of draw. Like, we've been doing this for years, but we do it people sit down, look at the data and say, oh, look, this correlates with this correlates with this, and those kind of things. How does a machine sort of step in the middle there? And how do you focus it in on just a few variables to say, so that it's actually picking those things out and alerting you, not the Wellpepper team sitting in a room going, hey, I'm seeing this trend in this.
Well, it does start with the Wellpepper team sitting in a room, right? Like a human needs to label the data to begin with, which is kind of the secret of machine learning and AI. And, when everyone was very upset about the fact that there were people listening to utterances on the home devices, people are reading, previously are reading, what you've typed in to actually apply
your search
insight.
queries.
Yeah, your search queries, for example. So it does start with people, and then it goes into the black box that I'll have to turn over to Mike.
Yeah, I mean, the data labeling can be a fairly intensive process, and it's hard in healthcare too, because the industry approach to data labeling in a lot of cases is not very privacy savvy today. I mean, we've seen some press coverage of some of the issues with both Amazon and Google about contractors having access to that data. But that is kind of the industry approach today. Is you get kind of a group of call it group sourcing of people to go and label data that then becomes input to a machine learning training algorithm. In healthcare, we have to be careful about that because, for example, the message classifier that we trained, we looked at the data and said, well, there's a possibility that there's PHI in these messages, and so we really can't do that. We have to do all the data labeling ourselves. And so there's a sensitivity there with healthcare data about how you perform data labeling. But then after that, it's kind of the magic of machine learning. And there have been articles about, why is machine learning so unreasonably effective at doing what it does in image recognition, in diagnostics, in machine, self-driving cars. And the big answer is we don't really fully understand why it's as effective as it is. We know that it is. One of the trade-offs is we don't always know why it's making the decisions that it's making. So there's a loss of some visibility into the prediction mechanism when you train a machine learning classifier. That's an area of active research to figure out how do we build models that are not just accurate, but also predictable. Like we can explain why they predicted what they predicted.
Which is also, challenging in healthcare because, there's a lot of inconsistency today. And, first of all, people don't want something prescribed to their patient unless they understand why it's been prescribed. And, sometimes we'll see, you talk to 3 surgeons and you get 3 different opinions. I mean, there's a whole idea of getting a second opinion. So having that kind of closed box, we don't know where this came from, is challenging, which is why, again, it's got to be this kind of baby steps. The steps have to be, all right, let's see what things we can identify. And if we can identify them, then let's use that to scale the clinicians. Right. So present to the clinicians, hey, we've identified this patient might be a greater risk of readmission. And then maybe suggest to them some actions that they can take, or maybe just say, we've identified this, and it just is enough of a flag for a person to reach out and see what's going on. So it absolutely cannot be without people in healthcare.
Yeah, absolutely. The conversations we've had around AI previously, just the physicians who we've had talking about it have said, I just think about it as, just another opinion, right? So it sort of comes through and says, hey, look at this. And I say, all right, well, that's the computer's opinion based on this data. Here's my opinion. And I'm going to get another consult just to weigh those things. The other thing that was fascinating to me was we did one of those projects. Our team all had their own personal time to do projects, and 2 of the players went out and just got, TensorFlow, and that they just brought all this stuff in, and then they fed the images through and the results of the images through, and they were starting to predict. I mean, these are just two people sort of hacking in the corner of an office who have access to obviously healthcare data, but they were going through it, and they were approaching 80, 85, 88, 90% accuracy on image reads after like a month of work.
Yeah.
Which, I mean, sort of talks to your, it is effective. We're not entirely sure what's going on behind there, but it's pretty interesting that it's that effective. But let's talk about bias for a second. So how does bias present itself? I assume it presents itself through the data, and then what are we doing about bias? How do we prevent bias?
I mean, Mike pointed this out, like the EMR data is biased because it's biased towards billing for the most part. And, unfortunately, a lot of the data is not clean. You've seen the burdens of documentation, stuff gets copied and pasted, stuff is like, we know that this, this billing code applies and the patient has this, but like the number of times, I'm sure you've had this as a patient where, someone is reading something back to you and saying, is this correct? And you're like, no. The one that always gets me is when they read the medication list and like, are you still taking amoxicillin? Well, of course not. That's a 7-day course. So, the data is missing a lot of information. It's missing what happened really with the patient. It's missing what's happening with the patient in their daily life, which is those activities of daily living are the things that really affect your health. It may also be missing the opinions of the full care team. So, who has actually done the documentation in the EMR? And, I was thinking back, we don't know how it does it, but it does it. Think about like when you see doctors, especially new residents are told, if a nurse thinks something is wrong, believe that nurse. So, is that, that hunch that a nurse had that a patient is about to code or something like that, is that in there too? So when we're looking at, we'll look at patient, when we're looking at patient data, is it the full spectrum of what's happening with that patient? And then also, are we exacerbating human bias? I think back to one of the, starting this company was a result of an experience that my mom had. She actually faced a lot of bias before she got diagnosed. And there was bias, I suspect, about her age, and possibly, I just finished reading a book that I blogged about data bias, that there's a lot of data missing on women because studies were not done on them because of, some famous studies where there were problems, the thalidomide example, but then because of that, there's a whole lot of data missing. And so, a heart attack presents differently in a woman than a man, but we don't actually have the data to show, like as a woman, I'm reading this thinking, how will I know if I'm having a heart attack? And it seems like we won't. So I think that the thing we've got to recognize before we go too far down this path is, do we have all the data and how do we get more data? And that's what, we're quite passionate about the fact that the patient generated data, the experiences of, why didn't you take your medication? Was it a side effect? Was it, you couldn't afford it? All of those additional things around it, because you could come up and say, well, our data shows that patients on this condition just don't take their medication. Well, that's only part of the information. Why didn't they take it? Is it something to do with the side effect? Is it something to do with the condition that they have? So I think I'm worried that we get a little too far ahead of ourselves. Like, we need to stop and say, okay, if I'm feeding this data into the machine, what bias might that data have just to begin with, because it's missing something? And think about all the questions that you can ask and how can you get that additional data? We think that you can get a lot of data from patients. I suspect, that's because that's where we're focused. We do get feedback from clinicians as well. What action did they take when a patient presented a certain alert? But really thinking about like all of those things that are happening and how do you get everybody, I want to say everyone's viewpoint, but there's a lot of stuff going on.
So a picture of someone's health is greater than their EHR data. We know that whole person profile is necessary. You're you have a bias towards collecting the data directly from the patient. Go figure. That sort of makes sense. But where are we going? Are there other sources of data that we can sort of tap into? I mean, and even are there some limitations in the patient generated data as well? So I guess those are two questions.
Yeah.
Limitations, and then are there industry initiatives that are starting to aggregate information outside the EHR itself that are valuable that we can tap into?
Yeah, I mean, there's definitely limitations in the data that you collect from patients. And I mean, some of those are kind of obvious things like, well, will the patient actually respond to all these surveys and questionnaires that we're giving to them? And so there, you have some percentage that do and don't respond. And there are, there's some percentage of the data you get from patients that, may not be totally clean. The data that we have says that patients, when you ask patients kind of continuously and ongoing about, to report their condition and things that are happening, they're more likely to be truthful if they're reporting it in the minute than if they are sitting in your waiting room trying to fill out a retrospective form of, what symptoms did I have? They tend to misremember things in that scenario. So we believe in kind of trying to capture things as real time as possible, helps keep that data as clean as possible. And like there are a ton of new data sources that I think are starting to feed into healthcare. There's a lot of interest in data coming from sensors, whether that's activity data or weight data or blood glucose, or there's a ton of information that we can capture about patients. I don't think we know yet what that data means, and that's kind of the classic problem today when you have reports of patients that bring in their Fitbit printout to their doctor and say, well, what does this mean? And the doctor says, well, I have no idea. There's no clinical significance to that. So there's a missing step there of taking that kind of sensor data, merging it with all the other things we know about the patient to draw meaningful clinical insights. And then the other big piece is on the genomic side. There's a lot of companies like the Project Baseline initiative from Verily that are starting to study that. Like, let's look at a whole bunch of people. Let's take their genetic information as well as all of their kind of daily livings and measurements, and start to understand like how does people's health progress over time. I think that's a super meaningful and useful data set that will take decades to collect. But the way we practice medicine in 20, 30 years will be different than the way we do today because of that.
I think we're also seeing the government making data sets available as well to compare to. I think definitely, I don't see the two things coming together. Again, this is like, I think we're in the stage where there's a lot of data and people aren't taking this data and putting it with this data to see what happens. It's like, there's one group who's looking at claims data. There's another group who's looking at patient-generated data. And it is hard to bring those things together. And frequently, like, when we're working with a health system, we're always looking at, hey, how do we prove for you the outcomes that we're getting? But also, the outcomes can include things like cost. Well, frequently, the surgeons that we're working with to improve the outcomes are not the ones who have the cost data. I think that's the opportunity, is trying to figure out how do we match these data sets? How do we get them together? And then, there's also like a little, I want to say chicken and egg thing, but you saw with Propeller Health, they were able to predict air quality based on inhaler usage. Shouldn't we be flipping that around and think, okay, the air quality is going to be bad or is bad? Like, let's, that was actually something that a physician in Kaiser said to me, because they do take a population health management. He said, this was in Seattle, where we had last summer some pretty terrible air quality from forest fires. And he said, how can I need to go tell all, all my patients with asthma what they should be doing? And he had no way of finding that. So he had the data, the environmental data. Every day we saw the air quality rating. And then he had no way of actually matching that with his patient data to say, all of you people, here are the things I want you to proactively do because this is going to affect your health. So I think we're at the point of knowing that there are these large data sets and knowing that there's valuable data in individual data sets, putting them together, that's going to be the thing that really breaks through on health.
Wow. So still the best way for us to communicate bad air quality is through a sign on the road, a radio broadcast in the morning, and TV news. Is that what I hear you saying?
Well, I was always asking my phone. That was my, every day I'd wake up and be like, what's the air quality? Siri did a really good job of that and would tell me the number and then pull up a whole chart of what it was. But yeah, I mean, but then you want Siri, I don't know if I want Siri, but somebody then to say, if I'm at risk, I mean, we were all at risk because it was so bad, but hey, here's what you should do. Proactively use your inhaler, stay inside. People were, the news was saying, this is how bad it is, and you'd see people jogging, and they didn't know, and that goes back, and the Kaiser doctor was like, I want to go tell people they should not be doing these things.
So let's talk, I use the term Silicon Valley here, and I probably shouldn't since you guys are in Seattle and some of the players are in Seattle. So let's just call it, the tech industry, their use of data. So last week, Microsoft, Amazon, IBM, Oracle, I don't remember who else, they all signed their pledge to share healthcare data. And I talked about it on Tuesday's show. What does this really mean? I mean, what do you think it means to the industry?
Yeah, I mean, I think there's an increasing movement towards openness in patient data. Certainly you've seen from some of the regulations coming out of CMS towards giving patients access to their own data, I think is a huge step in the right direction. For too long, we've had patient data that's locked and siloed inside of healthcare systems. In terms of big tech using that data, I think there's a lot of good that can come out of that. I think there's a need for kind of the right privacy controls to be in place and kind of the acknowledgement from those health systems or from those big tech players that health data is a different animal than a lot of the other data that they deal with. And it's really easy to inadvertently leak PHI, even data sets that you believe may be de-identified. Like there's certainly cases of people easily re-identifying data. So I think with the right focus on privacy, I think it's a promising trend. There's a lot more good than bad that can come of it. But I think there needs to be careful rules put in place by those health system or health big tech companies to kind of self-police, I guess.
All right, so let me drive this conversation. So if you get a certain part of the industry, those tech or those executives in a room, they'll say, look, I'm all for giving the patients their data, but they're going to be used and abused. People are going to get that data. They're going to give it away. We need to find ways to protect that data. And essentially what they're saying is they can't share the data with me because they think that I'm not sophisticated enough to know how to protect my own data. I mean, what mechanisms are we going to put in place when, and you have it on your phone, and Mike, you have it on your phone, and your parents have it on their phones, and now all of a sudden they have this great data set that you guys know how to use, and people who understand big data and machine learning and AI can start to create some really interesting things around. But what they're afraid of is not Wellpepper and the good actors. They're worried about the nefarious actors who are already calling them every 5 minutes to try to get their social security number, now getting access to their entire medical record.
Yeah, I mean, I don't think that's an easy problem to solve, and it's not related to healthcare. Like the number of people who have their email address with their date of birth in it, like the number of people who have their date of birth published on Facebook, like it does seem like perhaps data privacy needs to be taught somewhere. I feel like, I'm going to say particularly paranoid, but I remember, I guess back in the 90s being concerned about who had my data. And then Mike and I worked at a company that was acquired by Microsoft. And I was like, okay, well, I can trust Microsoft now because I have to, because not only, do they have my date of birth, they have my social security number, and they have my retirement plan, and my healthcare. So, they pretty much know everything about me. But before that point, I was pretty concerned about who received my information. I think that, on the one hand, it's my right to, I want to disclose anything to you about my health. That's my right to do that. I want to put I did put my x-rays on the internet when I broke my finger because I was, I always like to blog about healthcare experiences. But at the same time, I think most people are not understanding about privacy in general. But on the other hand, I'm talking myself in and out of things, but on the other hand, who's protecting our data. We look at some of the most recent breaches, things like Equifax. I mean, that their whole job is protecting people's data. So, is it about educating people or is it about changing the systems? I don't know.
At the end of the day, you have to think about whose data is it. If I'm a patient, is it my data or is it somebody else's? And certainly when in our contract, our standard language is that the patient data belongs to the patient. We have license to use it for your care, but it's your data. And if you take the approach of the patient's data belongs to the patient, that I think helps guide a lot of policy decisions on kind of how and when you release in smart ways. But I think there's a fundamental kind of ownership question there.
So that's interesting though, because Mike, here's the counter argument, because I get too many of these discussions. Not that I agree with the counter argument, but it is a counter argument, which is if I'm sitting here taking notes about you and Ann and how well you're doing on the podcast, just because I'm writing about you, is that your data?
Not necessarily, but what we have is patient-generated data. It's me saying, I took my medication, I'm feeling a little dizzy, I did this, what patient-generated data, I'm choosing to tell you, this is not your interpretation.
No, I agree with that 1,000%.
Yeah, the question, when it becomes your interpretation of it as a doctor, that's another, but if the doctor is doing something to you, that seems to be your data. Someone has done something to you, I don't know, that's a tricky one. Then you look at GDPR, the right to be forgotten.
Oh yeah.
How does that go with medical records? If I want to be forgotten, but then at the same time, medical records actually need to be kept so that we, know what happened. So it feels like we're, as same with machine learning, in the data to privacy, it's almost like sometimes the regulations and the technology are on totally different timelines.
Yeah. And I've said this on a couple of the news podcasts I do on Tuesday that, I'd like to press a button and have essentially you download my health data to me, and then I would like for it to go out of your EHR. And my case on that is, I just don't think, this is going to get me in trouble, but I do enough work within healthcare that I don't trust healthcare to protect my data. There's just too many things changing. There's too many mergers and acquisitions. And every time you do a merger and acquisition, you connect to another health system that has a security profile, and you just increase your attack vectors, because the attack vectors primarily are the people you employ. And so when your health system goes from 20,000 employees to 40, you now have 40,000 attack vectors to get into that health system. I just don't think anyone's going to say, oh gosh, I got to target Bill Russell and get his health data. That's not going to be worth it to them. They want to get 20,000 records. They don't want to get one.
Yeah. So you made the case. You own it, and you give people rights to it.
So what are you going to do with it? So Seema Verma is successful, and secretaries are successful, and actually even Joe Biden actually was making this case around cancer research, and he's saying, get that data out there. Okay, so that bipartisan, they're successful and say, all right, here's all the data. What are we going to do with it? What are some of the best ideas or best thinking around this is what we can start doing for patients if we can start aggregating all this data?
I think aggregating. Sorry, I thought you were thinking about.
No. If I gave it all to you, if I had it and gave it to you, what are you going to do for me?
What am I going to do for you?
Well, your company.
I think that's the big question, right? I think that's if you take the approach of big data sets can lead to big improvements, and we don't know what all those areas are yet that someone's going to discover. Links between health data and zip code data and air quality, and I think it is on researchers to be able to make good use of that data. And I don't know if we know all the places. We certainly see places where today machine learning is making early inroads on helping improve diagnostics and things like that. But I wouldn't try to. I'm not enough of a futurist to try and predict where we'll be in 5 years with kind of easier access to healthcare data.
I think it also.
So let me rephrase the question, because this is, I really want to tap into your guys' expertise. You've started a company, it's successful, you're growing it. So
we're just doing this little,
I I know this little thing with studies from Boston University and Harvard and partnering with Mayo. I get this little thing you guys are doing as a little side project. But with that being said, it has been successful. So it becomes what are if you guys didn't have this going on and you were just getting into healthcare and all of a sudden secretaries they're all successful and all this data, what areas would you like to see a startup start to tackle or go after that you think, man, that could really have a significant impact in the community where I live?
I would focus on seniors because of demographics and because we just don't have enough clinicians to care for everyone. So I would start to look at where can we really help people? What are the common things that people struggle with as they age, where maybe they don't need to be struggling if we knew certain things ahead of time. Everybody's concerned about Alzheimer's and dementia, but what can you do to help people be more independent, because everybody wants to be, and then also what can you do to connect them to their caregivers, whether that's their children or professional caregivers. And what I see right now in that space is remote monitoring is a lot of put devices there. I don't know that the devices are that's not enough. There's got to be a lot more about what's going on and how do you help someone be proactive. That's where I would focus.
Yeah, Mike
may focus differently.
No, I think there's a lot of kind of clinical and diagnostic things that are super important and kind of very domain specific. I think one of the big challenges we have in healthcare is we just have an unsustainably expensive model here in the United States. And so I think there's a lot around cost that we could do to understand, what are the patterns of how patients progress through diseases and which things actually do help cut costs. Is preventive treatment effective at helping bend the cost curve or not? And I think that needs to shape policy about how we pay for things in healthcare and help kind of continue to move away from incident-based payment and move towards kind of more value-based payment, and having a complete understanding of what does value mean if you understand how that patient progresses over a long course of time, not just with a few billing codes, but are they able to be successful at getting back to work after a health disruption, that sort of thing.
And I think as well, maybe if we can shorten the research, we've got the clinical trials and studies which you have to do, and then we've got the insights from machine learning. How do we bring those two things together to shorten the cycle? Because right now it's someone publishes something, it's 17 years before that gets into clinical practice. So we know things today that would improve everybody's life, but they're not necessarily in clinical practice. So how do you marry those two? Because the big data is also telling you something. Might be super interesting to match those analysis to studies that have already been done to further prove the study.
Fantastic. You guys are awesome. I love having you guys on the show, and having you both on is
That's
great.
why I wanted to bring Mike this time. I told him it would be fun.
And anything you want to leave our listeners with before I close out?
Don't underestimate patients.
I was going to say the same thing.
That's why you guys are together, and that's why you're doing the work that you're doing. Can they follow you guys? Just the wellpepper.com?
At Wellpepper on Twitter.
Yep.
It's probably the best place to get all our news. And then on our website, we've got our blog where we blog about all kinds of things, both things that we're doing, but general industry thoughts, always related to the patient experience, though.
Fantastic. Well, thanks again for coming on. Please come back every Friday for more great interviews with influencers. And don't forget, every Tuesday, we take a look at the news, which is impacting health IT. This show is a production of This Week in Health IT. For more great content, you can check out our website at This Week in, actually, I'm going to stop that now. It's thisweekhealth.com. I keep saying This Week in Health IT, but I changed the URL about 2 months ago. So it's thisweekhealth.com, and you can go to the YouTube channel, thisweekhealth.com, click on the video link, and you can see any one of our 800 plus videos that are out there. Thanks for listening. That's all for now.